morning everyone. We're going to begin our first session since it's an online session. I would like to invite our chairperson, Dr. Bikash Bhattacharjee, MBBS 1976, Guwahati Medical College from Guwahati University. And we have another chairperson, but he's not yet come in. So, sir, we're going to start the session. Yeah. He's coming. We called him, sir, twice. No. Yeah, it's here also in print, but we'll also be putting it. Come here, sir.
Someone introduce Eddie, yeah. So good morning. This is the last day of the great, wonderful scientific program. But last not the least, we have got a keynote lecture by none other than Dr. Anoop Misra. We all know about his contribution in the field of endocrinology and metabolic disease, specifically about hepato-pancreatic fat. And his today's lecture is very interesting for the reason that there is a hepatokine, Fat-Fetuin-A. An increased level of Fat-Fetuin-A can inhibit glucose-stimulated insulin secretion by beta cell, also can inhibit adaptive proliferation of beta cell and functional maturation of beta cell. On the other side, in the insulin resistance side, it inhibits insulin signaling by inhibiting tyrosine phosphorylation, tyrosine kinase phosphorylation, and by inflammatory pathway. So it is going to be a very interesting topic. And it is very interesting that lower level of Fat-Fetuin, if you can lower the level of Fat-Fetuin, maybe we can bring about the functional maturation of beta cells. So there is a way for reversal. So this is the topic, hepato-pancreatic fat, Fat-Fetuin-A axis for the pathogenesis and reversal of type 2 diabetes. Dr. Anoop Misra, please. Please play it.
Thank you, Dr. Banshi Shabu, Dr. Arvind, and the whole team of Diabetes India for giving me this opportunity. Unfortunately, I could not be with you because of last minute cancellation of the Vistara flight. I'm sure missing you, missing meeting all of you after a long time. The topic for today's presentation is hepato-pancreatic fat Fat-Fetuin-A based axis in context of diabetes and its reversal. I will be mostly talking about pancreatic fat. This is a little unknown topic, not very well researched and not very well talked about. Then I will piece together pancreatic fat as well as the hepatic fat and Fat-Fetuin-A, and then go on to discuss some of the modalities which can decrease these fats and possibly help in reversal of diabetes. I've divided my presentation into several parts. Part 1 is pancreatic fat and its relationship with age, obesity, and diabetes. While we know a lot about pancreas, how diabetes starts, it is pancreatic fat which is less researched. Pancreas lies in retroperitoneal space in upper abdomen. Its length is 12 to 15 centimeters, max width of 5 centimeters and thickness of 2 to 3 centimeters. Presence of pancreatic fat was first described by Ogilvy in 1933, and fat storage in pancreas is largely due to infiltration by adipocyte. That's one way of increased fat in the pancreas. And the second way is ectopic intracellular accumulation as lipid droplets. Now this is the anatomy of the pancreas, and you very well know it. Just to recap, this is the acinar cell. This is the beta cell here with alpha and beta cells. And this is the cells. These are the cells which are adipocyte, which have infiltrated pancreas. Of course, they will result in number of metabolic phenomena, and I'll come to that in a little while. The term non-alcoholic fatty pancreatic disease was introduced in 2007. Two groups of mice were taken, and on the left side you can see the lean mice, on the right side the obese mice, and you can see the infiltration by adipocytes, and on the right side are the exact numbers of interlobular fat, intralobular fat, and total pancreatic fat in obese mice, which is 2 to 3 times higher than that in the lean mice. So triglyceride represented 11% of pancreatic fat in lean mice compared to 67% of pancreatic fat in obese mice. And interleukin-1 and TNF-alpha were elevated in pancreas of obese mice, and 10. At this time, the terms NAFPD, non-alcoholic fatty pancreatic disease, and non-alcoholic steatopancreatic disease were introduced. This is the general classification of excess fat in pancreas. Pancreatic steatosis, pancreatic lipomatosis, and fatty pancreas are general terms used for pancreatic fat accumulation. Fatty pancreas, the replacement is used when death of acidocells occurs, and these are replaced by adipocytes. Fatty infiltration, when infiltration with adipocytes due to obesity. And NAFPD is used when pancreatic fat accumulation is coupled with obesity and metabolic syndrome. And NAP, which is non-alcoholic steatopancreatitis, is due to when pancreatitis is due to pancreatic fat accumulation. Now, there are several causes and consequences of pancreatic fat accumulation. I shall be discussing only a couple of them. The causes are well known. First, couple of causes are well known: obesity, metabolic syndrome, non-alcoholic fatty liver disease, age, alcohol. And there are several other rare causes: persons born with low birth weight, malnutrition, several drugs, and rare disorders like cystic fibrosis. Consequences which we shall be mostly talking about are impaired insulin secretion linked to insulin resistance, and there are some other consequences also like chronic pancreatitis, pancreatic cancer, and pancreatic exocrine dysfunction. How do we measure the pancreatic fat? It is, since the pancreas lies deep in the abdomen, it is sometimes difficult to measure in the exact manner. There are several modalities which have been used: ultrasound, CT scan, MRI scan. This is the current modality, magnetic resonance derived protein fat fraction. And some of these modalities have been how exact these are have been measured in the laboratory. For example, the magnetic resonance spectroscopy of pancreatic fat was measured against the fat as such by magnetic resonance spectroscopy to see whether the measurement in pancreas is similar to pure fat outside, and it was found that magnetic resonance spectroscopy is exactly measuring pancreatic fat. So that becomes possibly number one modality, followed by magnetic resonance derived protein fat fraction. And we have in our experiments used MR derived protein fat fraction. Now, a single MRI voxel reveals this, and because there are several voxels which are studied in any experiment or any research study. For example, we study 9 voxels in the liver fat and 3 voxels in the pancreatic fat. Now, as far as pancreatic fat, when we see one voxel, we see cluster of adipocytes, intralobular fat, interlobular fat, etc., etc. So, fair degree of pancreatic tissue is covered in a single voxel of MRI, and we take multiple voxels and then average the pancreatic fat. Coming to the part 2, major players in metabolism of the body as far as diabetes is concerned are liver and pancreatic fat. That this is becoming apparent, and there are a number of studies which have been done. And these studies are in evolution. A number of studies now have shown that pancreatic triglyceride increase with body mass index, and this is one such study. You can see the pancreatic fat evaluated by the MRI protein fat fraction, and as the BMI increases, the pancreatic triglyceride content increases. In this particular review, the pancreatic volume, total parenchymal volume, pancreatic fat volume, pancreatic fat and parenchymal ratio has been estimated over lifespan of people. So a couple of things become apparent, that pancreatic volume decreases over the age, and so does total parenchymal volume. But pancreatic fat volume increases over a period of time. So remember this. Like muscles, pancreatic volume decrease, and like ectopic fat deposition in the body or over advanced age, pancreatic fat volume increase. The second point which has emerged from this particular study was that the lean people have less pancreatic volume, less parenchymal volume, and less pancreatic fat volume. And you can see the black bars, which are representative of pancreatic volume, parenchymal volume, and fat volume in obese people. As we have seen in advanced stage, the pancreatic volume actually is less in patients with type 2 diabetes, and pancreatic fat is more. So as if we are looking at advanced stage where the volume is less and fat is more. Similarly, in diabetes, the volume is less and fat is more. And this is a summary slide from many studies where mean pancreatic volume was shown to be 33% less in type 2 diabetes than in normal glucose tolerance subjects. And pancreatic triglyceride content was 23% higher. Another thing which is very, very interesting, and I'll show you in the next slide, is that in patients with type 2 diabetes, the pancreas are typically involuted with a serrated border. And this is possibly because of the infiltration by the adipocytes. And once the pancreas has fat and volume is positively correlated with HOMA beta in diabetic subjects and in many populations. Now you can see here, this is the pancreas. And you can see serrated border. I have put markers there, serrated border, as compared to patients with normal glucose tolerance where there is no, the pancreatic outline is pretty smooth. The more the pancreas accumulates triglyceride, the more the blood glucose level, as has been very clearly shown in this particular study, that pancreatic triglyceride as it increases, it parallels increase in blood glucose levels. On the left side, you can see the adipocytes here, and you can see adiponectin here in pancreas. Also, the pancreatic fat is predictor of prediabetes in adults, and has been seen in this particular study, where you can see the pancreatic protein fat fraction is high in patients who have prediabetes and who are adults, and that is predictor. The odds ratio for prediabetes is pretty high when pancreatic fat is increased. Coming to the part 3, what are the cutoffs of pancreatic fat and what is the prevalence of non-alcoholic fatty pancreatic disease? So pooling data on pancreatic fat from 9 studies, 1,209 healthy individuals undergoing MRI, the weight mean and weight standard deviation for pancreatic fat were 4.48% and 0.87% respectively. And overall, considering all data, the normal pancreatic fat cutoff point was 6.2% on magnetic resonance imaging, and these authors have recommended that for future prospective study. Now, remember these cutoffs and these averages, because I will come to some of the data from India where the pancreatic fat has been imaged. Pooling data of NFPD from 11 studies, the pool prevalence of NFPD was 33%. Now, it is almost similar to non-alcoholic fatty liver disease. About 1/3 of the population has NFLD, and so has fat in the pancreas. And it is significantly it increases risk not only for diabetes, but metabolic syndrome and hypertension. Moving on to part 4, twin cycle hypothesis, because here this is the crux of my lecture. That's where pancreatic fat meets the hepatic fat, and also there is a great role of Fat-Fetuin-A here, which ultimately leads to insulin resistance. Now, this is the twin cycle hypothesis. This is taken from Rod Taylor's article. We know that muscle insulin resistance is one of the most important point of start of the glucose intolerance. So there is a somebody has pre-existing muscle insulin resistance, over which there is a positive calorie balance, which increases liver fat, and there is a hepatic insulin resistance, which leads to increase in the basal insulin secretion and increase output of triacylglycerol. Triglyceride is poured out of the liver. And the subcutaneous fat is one which actually absorbs a lot of triglyceride, and its capacity is exceeded, and then it goes to islet cells where it is deposited, which further leads to decrease in the insulin response and further increase in the postprandial plasma glucose. So one cycle is liver cycle, the other is pancreatic cycle, and background is the pre-existing muscle and insulin resistance. This is the key slide. You see, the main drivers for increase in the Fat-Fetuin-A are blood glucose and saturated fat. What is Fat-Fetuin-A? It is the hepatokine, and which is bad for the body. Now you see here, increase in the glucose and increase in the sat fat. Here role of sat fat comes. Some people say sat fat is not bad. Here is the role of sat fat. Through several pathways within the liver, they increase Fat-Fetuin-A. Look at this, they increase in the Fat-Fetuin-A, which in turn blocks insulin-stimulated glucose transporter 4, protein kinase B, and downstream signaling pathways in several organs, predominantly in the muscle cells and adipocyte, leading to insulin resistance, and also affect immune cells to increase inflammatory cytokines. So this is how Fat-Fetuin-A is injurious to the body, and it all starts with the increase in the fat in the liver, driven by high glucose level, high saturated fat level, and interestingly, decrease in the Fat-Fetuin-A level leads to increased vascular calcification, heart failure. So both ways it is bad. Part C of this particular section is how infiltration of adipocyte impairs beta cell function. Now you see, this is the adipocyte-free islet, and here is the fatty islet. And once there is a fat in the islet, the toxic cytokines are increased. Significantly higher number of CD68 positive cells were found in islets residing in vicinity of adipose. This leads to inflammation and further decrease in the beta cell function. So again, this is the key slide. This is the healthy liver. There is not much of increased sugar and fat to increase Fat-Fetuin-A. This guy is working out well, doing good amount of exercise, and the pre-adipocytes are not stimulated in any way. Macrophages are resting, and islets are not affected in any way. The moment there is some increase in the fat as well as sat fat, Fat-Fetuin-A increases, and along with palmitate also increases. Now palmitate impairs or causes beta cell apoptosis. There are several pathways of impairment of beta cell function and inflammation. One is the pathway through pre-adipocyte, through toll-like receptor 4, and it increases the inflammation. Resting at macrophages become pro-inflammatory macrophages. on islet cells, Fat-Fetuin-A again acts through toll-like receptor 4 and independent of that, also causing inflammation and causing impaired in the insulin sensitivity and also secretion. So this is the key slide, which is linking hepatic fat, saturated fat ingestion, increase in the blood glucose to adipocyte infiltration, bad adipocyte within the beta cell, and beta cell dysfunction due to increase in the Fat-Fetuin-A and palmitate. But this is not all. This is actually dictated by the genetic structure of the individual, and if there is infiltration of adipocytes in the pancreas, but there is no genetic risk of type 2 diabetes mellitus, then the blood glucose levels remain normal. Insulin does not increase, and insulin sensitivity is maintained, while impaired insulin secretion and resistance may occur the moment genetic risk increases. Coming to the part 5, exocrine pancreatic function, pancreatic cancer, and NFA-LPD. This is the CT image of a 63-year-old man. Patient is lean. Pancreas shows changes in the, you can see here, changes here. Changes in the fatty composition, but this person has both pancreatic endocrine dysfunction, C-peptide immunoreactive is low, and pancreatic exocrine impairment. So pancreatic exocrine dysfunction may occur in 33% of patients who have the adipocyte infiltration of pancreas. So this must be kept in mind. Another factor which must be kept in mind, that obesity, diabetes, dyslipidemia, we know by now they lead to increase in the fatty infiltration interlobar and intralobar, and which increase inflammation. That part we know by now. But what is not known often is that they increase KRAS activation, and precancerous lesions may become cancerous, and many of the people may develop the pancreatic cancer and may have metastasis before they know it. So pancreatic fat may lead to increase in the risk of pancreatic cancer. Part 6, and this is the last couple of slides that, of this lecture, which I am going to talk about. What about the pancreatic volume and fat in various ethnic groups? And what about Indian population? This is two slides of pancreatic volume from two different patients from one of our study, which was published in Journal of Diabetes a couple of years back. On the left side is the non-obese patient with type 2 diabetes. Now this is the newly diagnosed type 2 diabetes. And on the right side is non-obese, non-diabetic subject. Both are young, 25 to 27 years of age, and with the non-obese BMI of 21.9, 21.1, body fat which is not very high, but yet you see that the pancreatic volume is higher in patients with diabetes. Now this you may think is not in line with the previous data which I have shown, where the pancreatic volume may be decreased in patients with diabetes and pancreatic fat may be higher, but this is what the data from Indian population is. These are pretty young patients and they're non-obese patients. And what about pancreatic volume in various population? And you can see this is a slide taken from one of the articles where our work has been quoted. And in this non-obese, non-diabetic subject, we showed that pancreatic volume was 53.2, and this is all in cubic millimeter. And this was 26.6% higher in patients with diabetes. And if you look at the other population, 89.6% in Canadian population, and 79 in Japan. This is centimeter cube. So based on these review of multiple studies, the normal pancreatic volume these authors said was between 71 to 83 centimeter, and you can see it's clearly vitality volume in our population, at least in small sample of our population, is lesser than the other studies and clearly lesser than the white Caucasians. But then there may be ethnic differences. And you can see here the volume and fat has been compared between Koreans and Caucasians. The pancreatic fat in Koreans was 22.8% greater than Caucasian. And you can see very well that while the volume is lower in Caucasian, the pancreatic fat content is higher. And finally, which modality could decrease pancreatic fat and what is significant, whether it lead to the reversal of diabetes? This is a particularly interesting topic, and you must have heard Dr. Arvind talking about reversal of diabetes. Here is something which I'll present, which actually predominantly will talk about the reversal of diabetes based on decrease in the pancreatic and hepatic fat. These two fats are as well as between pancreatic fat and type 2 diabetes. In general, pancreatic volume decreases with age and in diabetes, while pancreatic fat increases with both. Ethnic differences in pancreatic volume has been reported. Very few studies have been done from India, and most of the data have been reported by our group. Fat-Fetuin-A is a key metabolic regulator, and if it increases, it is bad for health and increases decreases insulin secretion. The beta cell apoptosis may occur, and so we need to have decrease in the hepatic fat and decrease in the pancreatic fat to decrease the apoptosis, decrease Fat-Fetuin-A level, decrease palmitate level, and lead to better insulin sensitivity and possibly reversal of diabetes. So we can use hypocaloric diet, exercise, bariatric surgery, and emerging pharmacological intervention among the SGLT2 inhibitors and possibly GLP-1 receptor analog can reduce pancreatic fat content. Clearly, I have shown that decrease in pancreatic and hepatic fat and decrease in Fat-Fetuin-A level could lead to reversal of diabetes. So once again, I thank Dr. Banshi Shabu, Dr. Arvind, Dr. Chavla, everybody who's involved in the Diabetes India conference. I have been following all the events through WhatsApp. The conference looks great, great lecture and great participation. I am missing the action, the academic agenda there. Once again, thanks to all of you for listening to me virtually.
Thank you, Dr. Anoop. I think we miss you here in the physical form, and then you had to miss your flight. It's very unfortunate, and thanks for sending this recorded one. We are trying our best to get him online now from Delhi. Dr. Banshi is trying. In the meantime, if anybody has any questions, probably we can be ready with the questions. The same can be asked to Dr. Anoop.
Dr. Anoop, are you listening us?
Okay, I think we are not getting him. Okay, I think, sorry about that, and that was a great lecture. I wish he was here in person to give this lecture. I think with that we will conclude this first session.
Are you listening, Anoop Misra? Hello? Hello?
Yeah,
yes, sir. So we just concluded, and Dr. S.R. Arvind just wants to tell a few things.
Dr. Anoop, can you hear me?
Hello? Yes. You can listen us, sir?
Can you hear us?
Yeah, I can hear you.
Okay, good.
Thank you. Anoop, there's only one question between the hepatic fat accumulation and pancreatic fat accumulation. Which is more important for reversal of diabetes? Any idea?
Yeah, okay. Arvind, this is a hard question to answer because I feel that both are important, and as yet there is a more research in hepatic fat and less research on pancreatic fat. But as I showed you in the one of the slides where twin cycles were presented, both are inherently interlinked. And once the hepatic fat increases, there is increase in the Hepato-pancreatic, which goes to the pancreas and destroys the beta cells. So I feel the events start somewhere in the liver and then they cascade around to pancreas. However, both are inherently interlinked and it's hard to say which one is more important.
Okay. I'm just waiting for the audience if they have any questions. Otherwise, in the meantime, Dr. Anoop, one last question before we let you go. Are there any cost-effective imaging techniques that the clinician can use to pick up hepatic and pancreatic fat in people with IGT or people with a strong family history of diabetes, so that we are likely to pick them up earlier for reversal or probably for prevention of diabetes?
I couldn't hear the first part of the question, but I'll give you a general answer. The genetic link is absolutely important, and I showed one slide where people who have genetic predisposition or family history or some genes like PNPLA3, which predisposes to hepatic fat accumulation, may lead to further problems and more severe diabetes in those people, but nobody has proven that in a definitive manner as yet. But there is no way of going around that genetics is not important. Genetics is terribly important, and we need to have more research studies as far as genetic of pancreatic fat is concerned, because a number of studies have been done as far as genetics of hepatic fat is concerned, and a link of both of them. For example, PNPLA3, we have researched in Indian population, and we have found a very high odds ratio of having a non-alcoholic fatty liver disease in those people who have PNPLA gene polymorphism. And whether the same is working for the pancreatic fat, I don't know. But we are working on several studies on pancreatic fat at this point of time. And I think it's terribly important as far as the Indian population is concerned, because the recent data show that even people who are non-obese, who have BMI less than 23, and if we decrease pancreatic fat and liver fat, there is a potential for reversal of diabetes. So reversal of diabetes not only for those people who are obese. I think we should extend it to non-obese people as well.
Thank you, sir. So with this, we end our keynote lecture. And thank you, Dr. Anoop Misra, and we really missed you. Thank you very much once again. Thank you.